Hello, everyone. Welcome to our lecture on valvular heart disease, where we're really going to be focusing on mitral valve prolapse. So we're going to go over all the different mitral valve issues. So this is part of our perfusion concept in HCC2. Valvular heart disease is a really significant cardiovascular concern because it impacts blood flow, cardiac function, and overall perfusion. So again, we're going to talk about mitral valve prolapse. It's one of the most common valvular disorders, but again, we're also going to talk about mitral stenosis and mitral regurgitation as well. So throughout this lecture, we're going to look at these issues with the mitral valve and understand what happens whenever these valvular issues occur. All right, so we're going to start our discussion with mitral valve stenosis. And this is a condition that primarily results from rheumatic carditis, which is a complication of rheumatic fever. And what happens is it leads to fibrosis and calcification of the mitral valve. So the valve leaflets get fused together and they become really stiff. And then the chordae tendineae contract and they shorten. So as a result, the valve opening becomes narrowed, and this restricts blood flow from the left atrium into the left ventricle. So because we have this restriction of blood flow, it's going to increase the left atrial pressure, which is going to cause left atrial dilation, pulmonary artery pressure elevation, and right ventricular hypertrophy. So initially, the pulmonary congestion and the right-sided heart failure develop, which leads to symptoms like dyspnea on exertion, orthopnea, and paroxysmal nocturnal dyspnea, which is just a sudden shortness of breath that occurs at night. And as the condition progresses, symptoms can include things like palpitations, a dry cough, hemoptysis, which is coughing up blood, and even pulmonary edema. Right-sided heart failure are going to be signs like hepatomegaly, which is an enlarged liver, neck vein distension, and pitting-dependent edema. And again, this is happening in the later stages. Whenever we assess a patient with mitral stenosis, on palpation, their pulse may feel normal and may also feel rapid or irregular. AFib is a very common complication of mitral valve stenosis. So if you detect AFib in a patient with this, it's really important to notify the provider immediately because this can signal that there's some decompensation happening. One key auscultation finding here with mitral stenosis is going to be a rumbling apical diastolic murmur. And that's just the result of that turbulent blood flow across that narrowed mitral valve. All right, so moving on to mitral valve regurgitation, which is also known as mitral insufficiency. So this happens when the mitral valve does not close completely during systole, which allows blood to leak backward from the left ventricle into the left atrium. So this backflow or regurgitation, it increases the volume of blood in the left atrium, which then needs to pump more blood into the left ventricle during diastole. So over time, this excess volume is going to lead to left atrial dilation and left ventricular hypertrophy as the heart is trying to work even harder to compensate for this. So our primary causes of mitral valve regurgitation are mitral valve prolapse, rheumatic heart disease, MIs, connective tissue disorders like Marfan syndrome, and a cardiac inflammatory disorder, which is called infective endocarditis. So typically, mitral regurgitation progresses slowly. Patients may be asymptomatic for years, but as the left ventricular function declines, then we start to see symptoms start to emerge. So we may see fatigue, chronic weakness, dyspnea on exertion and orthopnea, palpitations, and atypical chest pain. And then as the condition worsens, then we start to see signs of right-sided heart failure where we see systemic congestion with jugular venous distension, liver enlargement, and pitting edema. With mitral regurgitation, whenever we're assessing these patients on auscultation, a key finding is going to be a high-pitched systolic murmur at the apex, which radiates to the left axilla. So in severe cases, we may also hear an S3 heart sound, which just indicates there is some ventricular overload occurring. Okay, so now let's focus on mitral valve prolapse. And this is a very common valvular disorder that can lead to mitral regurgitation. So in mitral valve prolapse, the valve leaflets enlarge and they prolapse into the left atrium during systole, meaning they don't close right whenever the left ventricle contracts. So this abnormality typically is benign, but in some patients it can progress to a more significant mitral regurgitation. The causes of mitral valve prolapse can vary. It's been associated with Marfan syndrome, which is a connective tissue disorder, as well as some different congenital cardiac defects. There's also a family tendency, meaning that this can run in families. However, in most patients, there are no other cardiac abnormalities that are present. As far as symptoms go, patients, again, are typically going to be asymptomatic. They may not even know that they have a mitral valve prolapse. But whenever symptoms do occur, then we may start to see things like atypical chest pain, palpitations, which may be associated with different atrial or ventricular dysrhythmias. They'll have some exercise intolerance just simply due to the compromised cardiac output. And they may also have some dizziness or syncope. Whenever we're auscultating a patient with a mitral valve prolapse, we may hear what's called a mid-systolic click, followed by a late systolic murmur heard at the apex of the heart. Interestingly, the intensity of the murmur does not necessarily correlate with the severity of the prolapse. So because mitral valve prolapse can sometimes progress to mitral regurgitation, it's very important for patients who do have symptoms to be monitored regularly. In most cases, lifestyle modifications and symptom management are sufficient, but in severe cases, surgical intervention might be required. All right, so now let's talk about assessing a patient with mitral valve disease. So first, starting with our patient history. We're going to get a comprehensive history so that we can evaluate the potential for a valvular disorder. So we're going to focus on family history, any previous heart conditions, so like asking the patient if they've had a history of rheumatic fever, infective endocarditis, or IV drug use, because IV drug use can cause infective endocarditis. We're also going to ask about their fatigue and how their energy levels are. A lot of patients may not recognize fatigue as a symptom, but it is an early sign of reduced cardiac output. Also, we may want to ask for whether or not they've had any presence of chest pain or dyspnea, because these can indicate that there's a worsening valve dysfunction occurring. On our physical exam, we're going to check their vital signs, looking for tachycardia or any irregular rhythms. We'll look for signs of edema, which could indicate some right-sided heart failure. We'll auscultate the heart and the lung sounds for murmurs, clicks, or crackles from pulmonary congestion. And we're also going to palpate the peripheral pulses for any abnormalities in strength or rhythm. And lastly, our diagnostics. So an echocardiography or echocardiogram is going to be the gold standard to diagnose any sort of mitral valve disease. And this is because an echocardiogram allows for visualization of the valve structure and function. There are some other tests that we can do. We can do a transesophageal or transthoracic echocardiography, exercise tolerance testing so that we can evaluate the functional capacity for the patient. Cardiac catheterization may be done to assess the valve severity and whether or not they're having any hemodynamic effects. And we can also do an ECG or EKG to be able to identify atrial fibrillation or any other dysrhythmia, which is very common in mitral stenosis and regurgitation. All right, so now that we've talked about the assessment of our mitral valve disorders, let's move on to our treatment options. Here we're mostly going to focus on valve repair and valve replacement. We can use medications. A lot of times patients are treated with medications, but some patients do end up needing surgical therapy. So one of the first things that we can do is just a valve repair, also known as a valvuloplasty. So this is going to be the preferred treatment over just a full-blown valve replacement, because a valve repair is going to be less likely to weaken the heart. A valvuloplasty helps restore that normal valve function, and it also preserves the natural valve structure. So some benefits for a repair versus a replacement. There's lower risk of infection. There's no needing lifetime anticoagulation, and typically there's a better long-term cardiac function, which is the valve repair. Now, whenever a repair is not an option, then a valve replacement can be performed. And we have two main types of prosthetic valves. We can have a mechanic valve or a mechanical valve or a biologic or tissue valve. So our mechanical valves, these are man-made. They're durable, they last a lifetime, but they require lifelong anticoagulation therapy with warfarin to prevent any clots from happening. Patients who have a mechanical valve need to maintain a therapeutic INR range of 2.5 to 3.5, taking this warfarin so that we prevent any clotting complications from happening. A biological or tissue valve, on the other hand, so these are made from cow, pig, or even human tissue. One big advantage of this is they don't require lifelong anticoagulation, but they tend to wear out over time. They typically only last about 10 years before they need to be replaced. So the choice between a mechanical and a biological valve really depends on things like the patient's age, their lifestyle, and their ability to tolerate anticoagulation therapy. For younger patients, a mechanical valve is usually going to be preferred just simply due to its longevity, but biological valves are going to be more common in your older adults or patients who can't take blood thinners. So understanding all these treatment options really helps us to guide patients in making an informed decision about their care. And that's all I have for this lecture, guys. See y'all later.